Aloha, Hawaii. It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and medical director, Dr. Randall Juleff of the Vein Clinics of Hawaii.
Well, hello there, and welcome back to our program. Glad to have you with us. If this is your first time, Vein Clinics of Hawaii, located on the Big Island, Kauai, Maui, and here on Oahu. It is the actual vein center of of Hawaii. And this is where you're going to get diagnosed and treated like, as a matter of fact, I had a treatment this week we're going to talk about in a bit. But right now, what we're going to do is, first of all, say hi to Dr. Juleff. Good day. Nice to see you.
Good day to you, too.
I want to talk about what we did to me a little later on, but I think this is kind of significant because finally, and we've been doing the show for a while, we want you all to know that the show is here for you. So we cover all kinds of things, really fun stuff, some cosmetic stuff, and some more serious stuff, some really big surgical items to do with your veins. Today is going to be the first of what we call our mailbag series, and this is where you, the listener, gives us some questions and tries to get some answers. And you'll find, if you have a preconceived idea, like I did years ago, when my mom was going through some really serious varicose veins, I thought, boy, if I ever get them, I'm not going to do anything about it. Things have changed so much, and that's what we're trying to do here, is bridge the gap. And you do that, I would imagine, regularly when people come into your office and haven't had any vein work except what they can remember from mom or dad.
That's a hurdle we have to go over all the time. Because the recollection of surgical vein stripping and what people had to do to have their venous problems treated, back in the old days, it wasn't pleasant.
Not a pleasant experience,
and that really does stop people from coming in and having things looked at.
But I can tell you one thing, friends. Today you walk in, you walk out, and there's a huge big difference in that. And I think that it's that, like Doc said, that, a lot of times some of the serious vein surgery that was done, you were in the hospital for a few days. I mean, your legs got all wrapped up and you were actually in some pretty not so fun times.
Not only the days spent in the hospital, but also the fact that most of those procedures were done with a general anesthetic. People were put to sleep, and in a lot of incisions. We really don't make any surgical incisions anymore. Everything we do is just through little needle puncture
Which
sites.
is, to me, it's unbelievable because once you learn, and this will come up today, the way that some of these veins are treated is they're treated from the inside. And you can get this little thing in there, a little wire in there. How it does its thing, I don't know. I don't want to know. But it does. It's amazing.
Yeah.
And it's basically heat or some sort of motion.
It is, yeah. And that all of that is the new technology of vein care that has kind of been developed over the past 20 years. And that is the crux of why it's so much easier now than it was before.
Okay, and gang, let me tell you something this is really important that you know this. And that was because things have changed. It's hereditary. And a lot of people never did anything. So this program begins with saying, my mother had varicose veins and they bothered her, but she never had anything done with them. Does that mean that I will also have them when I get older? And it is hereditary, so are you rolling the dice most of the time in most families?
Yeah, probably, yes. The genetic part of it, it's a hereditary problem. There's no question about that. And the genetic component is probably the most important thing. There are other things that then are affected also, lifestyle, becoming pregnant, professional life, those people who stand throughout most of their professional careers, like teachers and pharmacists and hairdressers. We see a lot of those kind of people.
Interesting that you should say that, because after our last show, somebody talked to me on the street and said, that they have been on purpose getting up. They work at a desk, and now there's more and more desks that are,
right,
so you can stand up working. And I guess the best is the combination. Because if you sit down too long, it's no good. If you stand up too long, it's no good.
Right. And there was a little bit of a fallacy of the elevated desk, because when they first came out, it was like everybody was feeling like they had to stand all day long in front of a desk, and that's a little counterproductive too. So like you said, the best thing to do is sort of a combination of standing and sitting. But the other risk factors are age, body habitus. People that are a little overweight tend to develop vein problems. And then gender, it's a little more prevalent in women, but I got to tell you, plenty of men have it too.
Yeah. And by the way, I've noticed this a lot, and we've been talking about veins for a long time, and that is a lot of men, it's like, I don't know, it's like cosmetic, and they just don't care, especially it's like things that they don't see, like maybe the back of the legs. If a woman has the back of a leg, somebody walking behind her will say, "Sally, what's that thing on your leg?"
Yeah.
And men, they don't care.
Yeah, right, sure.
Okay, but when you get to that, it doesn't always mean that you need venous surgery right away, does it? When you see something,
not necessarily. No. We see plenty of people with just superficial kind of problems that are basically just cosmetic, most of them don't need to go through any other procedure other than taking care of the cosmetic part of it if they want to.
If they want it, right?
But totally up to them.
Let's say both parents have it.
Yeah,
and so if you're. Is there anything you can do to prevent it? I think you've already answered this question in a different program, but okay, mom had it, dad had it, I don't want to have it. I'm going to take some of this, drink some of that, wrap this and wrap that. Yeah. I think it's just coming, isn't it?
Yes and no. I think that, getting back to your question, what if both parents, you have a much higher level of likelihood that you will have venous disease if both of your parents, it's almost a foregone conclusion. If you have one, you've got about a 50-60% chance of having venous disease. If you have both, it's around 90 or more. So, if both parents have it, then you probably will at some point in your life develop it. So then the next question is, well, what can I do to minimize it?
Exactly. What can I do?
Or avoid it? And, probably there isn't anything that you can do to avoid it if it's going to happen. If you've got the genetic makeup and, some other things, it's likely going to happen. But the thing that I think that people can do is they can minimize the ultimate result and also maybe put off it becoming significant and symptomatic. And in the way that the primary way to do that would be to wear compression stockings.
Yeah, and by the way, I used to think, because I was the only one that I knew wearing them, I see more and more of these as the days go by, because number one, they used to be, do you want the black ones or the black ones? Or I guess. And now they're coming in colors, even neon. And I think that there's other areas where also, I'm not going to say they're cheaper, but they are a little more affordable than they were in the beginning because there's more people making them.
Right. Yeah, there's more competition out there, so the price is going to come down. And
why are we wearing these things?
Well, because the compression stocking on the leg facilitates venous blood flow. And they call them graduated compression stockings because the greatest amount of compression is the lowest,
at the bottom,
around the foot and ankle, and then it diminishes as it comes up, and that pressure gradient tends to help flow upward, which is what you want. But I think for people who might be might have the genetics that might lead them to have venous disease in the future, especially if they are in a profession where they're on their feet a lot, those people, if all they did was to wear compression stockings consistently at work, then that would probably in other words, maybe you wouldn't eliminate having varicose veins or venous disease, but you could certainly limit the effect that it's having. Yeah,
see, but yet I was in your Honolulu office just the other day, and I noticed a display there, seeing some of the stockings like the ones I have, and then I saw a bunch that were the ones that I wear, by the way, are below the knee, just below my knee. These were up halfway through the thigh.
Yeah,
and is that the same idea?
Exact same idea. Those we use primarily when we're doing procedures on patients. Some people will wear thigh-high compression stockings on a daily basis, but most people don't because they're a little tight, they're a little hot, especially in a climate like Hawaii. People don't like a full stocking. So it's hard to get people to wear it, every day in a functional sort of fashion. But the knee high, I think, is doable. The knee high we use is a little less pressure up
at the top,
a little less compression than what we want people to wear for the thigh high, and they're a little easier to get on, take off. And also, there's so many different styles these days that really you can get whatever kind of stocking you want as far as, athletic stocking, a dress stocking, whatever you want.
Sure. And gang, there's any look, I try to get them on every day. I don't have them on today, but, I try to. And that being said, only your doc knows. I mean, if you get prescribed these things, or it's told you need to have these things, it's for a reason. I mean, it's not certainly not cosmetic. It's for a medical reason.
Oh, yeah. And when I go back to the office today, Mike, I'm going to put that in your chart.
Yeah,
You're not wearing your stockings today.
Shame on me.
That's the merit point.
But at least I admit it. Okay, so that being said, there's some things, like I said, that are visible and some things that are not visible. The ones that we always see are the little spider veins, right?
Sure.
Can you see some of the other varicose veins?
So spider veins are the tiny little, red and blue ones. Varicose veins are bigger, a little ropey.
Yeah, purpley or whatever.
And that kind of leads to our second question. Yeah. This patient wrote in, said, I have varicose veins. What should I do?
Exactly.
And that's a good question, because a lot of people are led astray by the concept that, gee, I have varicose veins. It's just a cosmetic problem. Mm-hmm. I don't need to look into it. And that is not the case. Typically, when people have varicose veins, nearly always that's an indication that there is a problem with the function of the deeper veins in the legs, kind of what you were getting at before.
This is like giving you a sign. You better take a look at this.
Exactly.
Yeah.
So, the first question, people come in and the first question is it cosmetic or is it a medical problem? But the step before that is the most important one, and that is that people need to recognize that if you have varicose veins, then it is very, very likely that the medical component is there. It should be evaluated, because it will sooner or later lead to problems.
Well, I know a lot of patients that end up in your clinics are there for the fun stuff, the aesthetic stuff that you do other than just the venous surgery. And mostly, I would guess, once they've had spider veins looked at, it would behoove them to go on to take the next step further. At what point in time does it become an elective surgery by the patient or a medical procedure by the doctor?
Well, the answer to
I'm here for my spider veins.
Yeah, so. And we get plenty of those patients.
Of course.
So the question always is, if they have something superficial, so the next question is, are they having symptoms?
Yeah. What are they?
That might be consistent with venous insufficiency, and the typical symptoms that we ask about are achiness, heaviness, fatigue. Do your legs get tired quicker than they used to?
I can see people out there right now putting yes on all three of those.
Yeah, many people.
It's just the way it is. Yeah.
And so many people think that, gee, my legs are feeling a little tired and they wear out quicker than they used to. But I'm getting older, and it's just a part of that. Well, not necessarily. Your legs don't have to feel as old as you think they feel. But swelling, is another common symptoms. Muscle cramping, restless leg syndrome, all those are things that we ask about. So if somebody comes in and has, let's say somebody comes in with just spider veins and they have no other indication of a vein problem, and maybe no family history and et cetera. Well, we may just say, okay, if you want us to treat your spider veins, we'll do it.
Come on in. Yeah. And that happens a lot. But there's also, I think, the ongoing, once a patient goes through the learning curve, because you spend so much time sort of explaining everything to them, is that, okay, I got these things, they're spider veins, but I really like to know if I can sort of take a look every now and again for them recurring, because they don't, you can get rid of them, but new ones come back, not the old ones. The ones you get rid of are gone. But, okay, let's just for fun see if there's anything else wrong with me.
Sure. Yeah. Well, and I think the other thing that goes along with that is that, we try to spend a fair bit of time explaining to patients what might be going on and what are the potential symptoms, because a lot of people don't know that they're having symptoms that might be related to vein problems, number one. Number two, the symptoms of venous insufficiency come on slowly and over such a long period of time.
Sneak up on you over 10 years or something.
That, everybody gets gets used to how their legs feel. And when we start to point out potential symptoms, they go, oh, gee, maybe I do have that.
Well, isn't it also true, Doc? And by the way, if you want to know more about what's happening here, you go to veinclinicsofhawaii.com and learn all about Dr. Juleff's practice and some of the gang that's there, some of the really, really unbelievable team. But I think that, when they say that with regards to the symptoms, I learned from you a couple shows ago, and I really carried that forward as a valuable piece of information. Is there's an awful lot going on in the legs? I'm coming to you for a venal problem. There's other things in there. There's arteries are in there. The lymph things are in there. There's bones in there. There's nerves in there. It's just a vein in the leg. There's a lot of stuff going on in there.
Yeah, there is a lot of stuff going on.
Therefore, I'm concerned about symptoms, because can't some of these symptoms be duplicative of maybe a different problem rather than a vein problem?
They could be. Yeah. So you have to kind of take, all of the complaints, as a group, and see if in general all of those are pointing in one direction or the other. But we have plenty of people that come in that are having symptoms from two different things, for instance, and nerve issues, disc problems in the back that are causing pain that radiates down the leg. That's a very, very common complaint in many people, and we try to. And they might have venous insufficiency also. So if we discover venous insufficiency, if we feel like they're having symptoms that are related to that also, then we kind of try to sort out which symptoms go along with which medical problem, so that people can have realistic expectations to their treatment.
And there is a reasonable expectation. There's other things that we can talk about, which I know we can. But getting back to this thing, if we're talking about somebody that is, they want to know if they have other veins outside of these spider veins. How do you determine that? How do you look inside my leg to see what's in there?
Yeah, if somebody has just spider veins and they come in and they are not sure whether they have other problems or not, ultimately the thing we do is an ultrasound. And
which I just had done this week. That was my clever lead into that. I was so impressed because some of you may have heard our program a few weeks back when the ultrasound technician Michael was as our guest, and learned exactly what I saw. When you can actually see a vein, and you can see by different pressure points how that vein is going. If the blood's going in this direction, that direction, it's fascinating.
Yeah.
So every patient must love to be able to see that. And it wasn't something that would have been maybe shared quite as, early in the piece, right? And now it kind of is, because you can see it on the monitor.
Yeah. You're right. I mean, before we had ultrasound, which was quite a while ago, but before we had ultrasound to look at venous disease, we did more complicated, extravagant kind of things, and what the results, the visual results, were not as impressive or as I think understandable to lay people as the ultrasound. I mean, the ultrasound gives us a fantastic image of blood vessels in general, but veins specifically. And like you say, we look for, the main thing we're looking for is abnormal flow patterns, and we can show that to the patient, and it
it's fascinating. Yeah, it really is. And by the way, it's come a long way. The original time I got ultrasound years ago was on this big, huge thing. It was like being in a surgery room. Now it just wheels in on this little tray. It's got a couple of things on it. They put the gel on there, bing, bing, and you can see it. Fantastic.
Yeah. The ultrasound machines, have gotten smaller and smaller. Most of the ones we use nowadays are just the size of a large laptop.
It's like a laptop. But Doc, there's something else that you should say, and I know this because of the quality of staff and personnel you have in the clinics. Anybody can buy an ultrasound machine. But Michael, the guy that we had in here as our guest, was so informative and so willing to share and show. When the doc finally comes in, when you finally came in, I already kind of knew that he was going to say this and that, because that's what we took a look at. I think that's very comforting to a patient.
It is. And you're right. An ultrasound machine, it's not, or the ultrasound examination, it's not like taking a photograph, where you can, stand behind a camera and click, and boom, you get a nice photo.
Yeah.
The result of the ultrasound is so dependent on the person doing it. I mean, it is tremendously dependent.
And what I was noticing, and I was actually kidding, because I said to Michael, the operator, you must be ambidextrous, because he's doing this thing with this hand and this thing with the other hand.
Yeah.
And he said, it's the job that made me be ambidextrous. Because what happens is, the results or what he's seeing there is transposed into a hard piece of paper that's going to track me. Now, and that means that in 6 months when I come back for a recheck, we're going to see what additional deterioration in that area there's been since the last time. That's really important to a patient, isn't it?
Absolutely, yeah. We do, I think serial, especially if we're looking at blood clots and, but other things too. We need to have kind of a picture over time. And the ultrasound does that for us in a very quick, easy, safe, non-invasive kind of way. Yeah,
and by the way, the report is fantastic. I needed one for a medical reason, and that's why I had my ultrasound the other day. But it really is, like I say, and if you haven't experienced it, if all you have is experience from a long time ago, or like we were talking about earlier, your mom or your dad, it's really, really come a long way. So what happens to me is the report that was generated goes to my primary care physician, who wasn't looking for a vein issue. He was looking for something else, but he needed to know that there weren't any pressing issues, and that's all documented right there.
Right.
It makes it easy for the docs.
Yeah, and that's a good point. Sometimes we're doing ultrasounds and we're evaluating patients to show that they may or may not have vein disease. A lot of times we're doing it to make sure that they don't have acute, sudden vein problems, and that indicates that their symptoms that they are having at that moment are probably due to something else, not their veins, which is sort of what you had going on.
Yeah, and I did this for a reason, because I've got some issues going on with one of my legs, and I thought, well, I know I have to have an ultrasound, and the first thing my primary care says, well, we're going to have to send you out for an ultrasound. I said, I know where I'm going.
Thank you.
That was a done deal. So once this has been determined, if it says, like I said before, if the next guy says, what if everyone in my family has big legs? And I always thought that was just genetics. But is there something else going on there? What controls or doesn't control the size of one's legs? A big person's going to have big legs.
Yeah.
But, aren't there sometimes little people on top that have big legs on the bottom?
There are. Yeah. So, part of that, this is a good question, because I've heard this a number of times in the past, where people come in and they're trying to explain off, they're trying to rationalize the symptoms that they're having, and swelling of the legs, and especially discoloration of the skin. People have 19 different reasons why they're having that, and and again, they're doing that because they don't know that swelling and discoloration of the skin can very much be symptoms of venous insufficiency. So there's a difference, between big and swelling, and some people do have big legs. That's just their body habit.
Okay, so I got big legs and I got swollen legs. That means it's double big. Right. And you can tell. Most people can tell after a while, this is not a good day for me.
Well, in most people that, tend to rationalize things in that way do have both. They've had big legs all their life. But now they're maybe getting a little bigger, and they're going, well, it's just because I'm big. But often it can be due to venous disease, and that patient needs to be evaluated.
Is there a line between obesity and venous disease?
Well, I don't know if there's a line. You mean connecting the two?
No, I'm saying that, if you are morbidly obese and you're really big, you probably have some issues with your venous system, because a venous system maybe wasn't meant to be really big.
Yeah. Yes. Yeah. The answer to that is definitely yes, because obesity is a risk factor of venous insufficiency. Obesity also leads to, or can be a component of lymphedema that we've talked about.
That's another reason why you can get swollen, right?
Yes. Yeah. So many obese people have both. Many obese people have venous insufficiency and lymphedema, in that both of those are the cause of their lower extremity swelling. and we need to address both.
Yeah, and that being said, are the treatment for the both similar? If somebody has, say, lymphedema, is that surgically done like veins, or is it done some other way?
Unfortunately, we don't have good, dependable kind of surgical procedures to address lymphedema the way we do for venous insufficiency.
I was wondering about that. Yeah.
So, lymphedema. Now, there are surgical procedures out there that people are trying to develop and perfect, and get a little more usable, user friendly. But we're not to that point yet. So if
you are working on somebody's venous, problems, and they're taking charge of their health and they're trying to be better, will lymphedema be aided also by wearing compression stockings?
Absolutely. Yeah. So
it's a multi-hit you get there.
Right.
Yeah.
The venous insufficiency, since there are things that we can do procedurally to improve that, we do. We take care of that, and we optimize their venous status. And then are they still going to have some swelling? Well, probably, because, they're going to have some continued swelling from the lymphedema. And lymphedema we treat primarily with compression of one sort or another.
It's very interesting. By the way, a lot of people say when it springs up like right away, if you're observant enough, you can tell if one leg's a lot bigger than the other. I guess that discovering something, that you have to know what you're looking for. It's not just, what causes something? If all of a sudden you wake up and one leg is swollen, what could they be? Lymphedema, varicose veins, all the above, until you get it looked at? Yeah,
well, if only one leg is swollen, then that kind of brings up a whole other set of questions. Okay. Typically, if you just have chronic venous insufficiency, usually it's going to affect both your legs in a similar sort of way, especially as it pertains to swelling. Lymphedema, same way. Now, are there some venous problems that can cause swelling in just one leg? Absolutely. For instance, if somebody develops a sudden DVT, deep venous thrombosis, blood clot, and that's one of the things that we always think about when somebody comes in with one leg that's swollen. Do they have a DVT? Other things that we look at or think about are, is there obstruction to the major veins going into that leg, higher up in the pelvis or even the abdomen, as a cause for one, swelling in just one leg.
Yeah, that's interesting though, because I think that if anything, that would drive people to look for attention if they could see a visible difference. Say, gee, this leg looks a lot bigger. Something must be going on in there.
Right, yeah. Right.
But once again, that could be several things. That's why getting tested is right away. Is this something that is determinable in the ER, or do you usually have to go out to a specialist like yourself?
Yeah, well, if somebody ends up in the ER with sudden swelling, and many people who develop a DVT, that's where they go initially. Either to their primary care doctor, or if they think it's urgent enough, to go to the emergency room. And can DVT be diagnosed or ruled out in the emergency room? Absolutely. Yes, absolutely.
It's kind of comforting to know that the healthcare professionals in places like the ER and stuff have got that equipment available today too. I mean, before obviously you have to go to a specialist, but I'm still convinced, by my own personal experience, that the quicker you get to somebody can sort of be the quarterback, like your GP, that can say, okay, you're going to go see Dr. Juleff, this is a vein thing, or you're going to go see Dr. Smith, that's a shoulder thing. You got to go to the right guys.
Right. Yeah.
Okay, so continuing on, what if somebody has veins, but the mother had vein problems, that she had vein stripping? We talked about this a little while ago, and this was almost like the kiss of death. I mean, it was certain punishment that you were going to have if you had your vein stripped. Right.
As we were talking about before, it's such a hurdle for people who have watched their parents or grandparents go through it, and it's a real deterrent, because they don't know that things are much different now. But it's one of the reasons that really stops people from coming in and being evaluated. They might think that, or they might think or even know that they have a vein problem that is significant, but they just choose not to have it evaluated because of these preconceived ideas about how it's going to be taken care of. And things are much different now.
Well, I'm also looking, and I think we've covered this a little bit on different programs. And by the way, Dr. Juleff and his staff can be reached at veinclinicsofhawaii.com. It's a very friendly website, got a lot of stuff there. veinclinicsofhawaii.com. Is that, as you progress through things, you got to take a look at the fact that we are standing up and working more years now than our parents did, and way more than our grandparents did. So, I mean, usually you get to 65 back in the day, you're at the white picket fence in your rocking chair. 65, we're just getting rolling on our second careers now.
Right, sure.
So how much more pressure or stress does that put on your veins when you're maybe not sedentary, or you're going to be more active for a longer time?
Yeah, that does matter. Mm-hmm. Because, we say that age is a risk factor for venous insufficiency, but really what that's implying is time is a risk factor. And the longer period of time that you're doing these activities that are also risk factors for venous insufficiency, then the worse it's going to get, or the more likely it's going to happen. People are living longer, they're working longer,
sure, and they're on their feet. Sure. Yeah. And there's another thing here too, gang, and I know that many of you are like this. I am, and I do know that one thing is, if you haven't had treatment and you get up in age, some of the treatment is pretty significant. I mean, and I guess maybe the benefit is, and the reason why we do the program and you have so much information that's going out, is to say that, look, you probably got it. It's probably not going to kill you, but it's going to affect your quality of life.
Sure.
So the quicker you get on some sort of a maintenance program of continually monitoring and acting on this, the better.
Well, it's certainly true that the earlier it's addressed, the easier it's fixed. I mean, there's no question about that. And as you alluded to, also, as people get older, the less able they are to, go through, any kind of procedure, no matter how minimally invasive it is. So it's better to take care of it when you're maybe a little bit on the younger side, so you don't have to go through the inconvenience of dealing with age and procedures.
Well, what I see now is doctors saying, nice to meet you, young man, and the guy's in his 40s. I mean, that used to be nice to meet you, Grandpa. But I think maybe look, if you work hard your whole life and all you want to do is you maybe have the bucket list, you want to go visit the kids back east, you should maybe address for us a little bit. I know this isn't in this particular question, but I have it, and that is the constant worry that people have about traveling. If they have venous conditions, that I know a lot of people either put off traveling or not travel because they're afraid of developing one of those deep vein issues, which we see every night on TV now.
That's an important thing to keep in mind for people, doing long distance traveling. Which, people from Hawaii flying to the mainland, that's a long flight.
Sure, 5.5 hours.
No matter which part of the country you're going to. We always recommend that people wear compression stockings. For pretty much everybody, but especially if you have venous disease. You really need to have some sort of compression on your legs. I mean, every time I get on a flight, I've got compression stockings on. It's just a knee-high stocking.
And by the way, he's like a slender guy, so he's doing this in advance. You can't say physician heal thyself. I mean, doing a procedure on yourself in your field would be pretty difficult.
It would be hard.
But I think really, and the reason why you can have a little bit of levity in this, because it's not all bad news. And what I've already seen and talking to patients and for my own self, you feel a little bit better when you know, first of all, what you have, and second of all, where it is and where can it be? How can you get treatment, and what will the treatment be? That's where you sit down with somebody and really map out the options.
Yeah, right. I think people have peace of mind when they know, they might think they have a problem before, but then they come in, they find out that really there is an explanation for my symptoms, and luckily there's something to be done about it. But, getting back to this question about, parents having, bad experiences with vein stripping, there's just so many things that we can do today that are so minimally invasive to treat the same things that they were treating. 20 or before 20 years ago, with a bunch of incisions and hospital stays. And I try to keep reassuring people that it's nothing like that anymore. And we really try to keep people absolutely as comfortable as we possibly can during the procedure.
When you talk about that, the procedure, let's talk about when and if a incision would be necessary. But from what I understand, some of them were very lengthy. I mean, sometimes didn't they have to go down, make quite a long incision to get at that vein and get it out of wherever it is there, pull it out of there?
Sometimes, but mostly it was just a lot of not real long incisions, but maybe an inch or two.
Like, is this like almost going to be where most of the valves are? That you have this?
Well, not so much where the valves are, but just but where the vein is running. Yeah. But for instance, one of the things that we do, or the way that we treat reflux in the main veins of the superficial venous system, back in the day, those main veins were ripped out of the leg. Ripped out. And for lack of a better term. Yeah. And so, nowadays, those main veins stay in. However, they're treated with either a heat mechanism or a mechanical mechanism or an injection kind of mechanism that causes them to close down, and that eliminates that abnormal flow problem.
Do they stay in there? Do they eventually dissipate? Or
the vein stays in initially, but over a long period of time, your body breaks it down.
Sure.
And usually, when we look at these veins, a year from now with the ultrasound, it's just a little fibrotic thread. So and that's all done through in a very minimally invasive sort of fashion, through just little needle puncture sites. I really don't remember the last time I made an actual incision to do a vein procedure. We do puncture sites and needle sticks, and that's about it.
And so the needle, in some of these that are close to the surface, the needle's all you need, right?
Yeah.
You find it with the needle?
Oh, absolutely. Yeah.
Zap it with a little, what do you call it, the what it is?
Sclerotherapy.
See, I'm getting to learn this stuff. Once you do that, and that just literally just says bye-bye. What I wanted to go back to, you said stripping before. I think that people can envision all these different parts in the leg, but it would seem to me that they've all be intertwined and wrapping all over each other. So it means that you can't just pull a vein out of there. It means that, isn't there some resistance? Do they not want to come out?
There is some resistance because, they're just anatomically connected to the soft tissue and the fatty tissue around them. Now, are those attachments really, really strong? No. I mean, they can come out easily, but yeah, it's not. And so many, if we're treating varicose veins, for instance, varicose veins we treat with a procedure that we call microphlebectomy. We make little needle puncture sites along the course of that vein, and then through those puncture sites, we have special instruments that we're actually able to extract those veins. To extract them, I get it. Now, those veins come out in short segments. It's not like you're unraveling a long piece of yarn or something. Unfortunately, that'd be nice.
That'd be the easy one, sure.
Yeah, but
you use a fishing reel and just crank it in.
Yeah, exactly. Yeah. So, but we make a bunch of little needle puncture sites. Now, those needle puncture sites in general heal very, very nicely, and in nowhere near as much of a surgical ramification of having these procedures done compared to what we did before.
Okay, well, I remember one treatment that I had, and that was after the treatment. There were several sites, many sites, about 30 of them, and there were these little owies that were all over the place. And I guess that's part of the explanation of the treatment that you're going to get from your doctor, that this is totally the way it's going to be. It's predictable. That the surgery hasn't failed. I mean, it's going to look kind of ugly before it gets better, but that's just because why? Trauma? And you get in there and jam things up. Why does it do that?
Well, we're even though we're going through just little needle puncture sites, we're still creating a fair amount of physiologic and anatomic trauma. And most of it is because many of our things are heat-based, but, practically everything that we do creates inflammation.
Sure.
So, and people, I think some people they come back after their procedures and they say, gee, my leg is still uncomfortable. Not painful, a little bit of discomfort, but it's a little deceiving because they don't have a bunch of incisions all over their leg. If they did have a bunch of incisions, they'd be coming back and saying, oh, okay, well, I had surgery. That's why I have a little bit of discomfort. So they expect, all of that inflammation to be eliminated in a much quicker fashion. But, it takes a little while.
And I noticed that. By the way, I had this one thing, and you can explain it was on the top of my thigh, and it was this big thing that went out like a spider's web, and it was there for years and years and years. And I used to my granddaughter, my daughter, and then my granddaughter, Papa, what is that? What is that? Does it hurt? You? And always wanted to touch it. Well, since that was removed, there's no trace of it ever been there. Yeah. And it went from the time that it was treated to the time that it went away was months. And I thought, this thing's never going to change. And then, lo and behold, it started changing. Now I can't even find where it was.
Yeah.
It's amazing.
It takes, some of the things that we do take a little while. And for instance, I think you probably had a spider vein that was injected. So you had sclerotherapy for a spider vein. And, the improvement that we see after that procedure goes on for several months.
Yeah, that's amazing.
And that's why we have to, sometimes we have to manage expectations, because I think a lot of people feel like, we're going to inject this spider vein, it's going to disappear.
Tomorrow you go to the beach, show off your legs.
Yeah.
Not quite.
No.
Yeah.
But so, it's a 3-month period. Now, it's good that it's 3 months because you have improvement in that process over a longer period of time. It's bad that it's 3 months because it takes 3 months before people can see the actual outcome. But you had a very good outcome.
Yeah, and by the way, the 3 months that it takes, it's 30 years that it took to get that way. So it's it's going to be a lot quicker. But you mentioned earlier, and I think we should go back to this. And by the way, if you ever have a question that you want answered in the mailbag, it's pretty easy. You can come to our site. You can go to Doc's site. You can go to veinclinicsofhawaii.com and contact us or give a suggestion of what you'd like to hear on the show. Or, of course, seeing me around the streets or sending me a note at themikebuckshow@gmail.com. You mentioned early of some of the things like the stripping and some of the things that when they used to use, they used to knock you out to get your veins stripped. They knock you out. And I'm assuming because it was painful. I mean, otherwise, why knock you out if you can do it local? So it must mean that back in the day, that procedure, not only was it cumbersome and hard, but it was hurtful.
Yeah. It was painful and just a fair bit more extensive with respect to, the invasion through skin and incisions and all that sort of stuff. So, and that's the other thing that has made these procedures so much more palatable for patients is the anesthetic part of it. It used to be a general anesthetic. Now, that not only was that needed because of what the procedure was being done, but that general anesthetic itself carries a certain amount of risk. So
can you or can you not, right?
Yeah, we've been able to get away from that, and nowadays we do something called tumescent anesthesia, and tumescent anesthesia is just a large volume of saline that we put a numbing medication into, and we inject that into the leg. So it's sort of like going to the dentist, where you
get that localized.
It's a local anesthetic. Basically, it's a local anesthetic, but we give a lot more than when you go to the dentist because we have to cover a much greater area.
Interesting enough to me, and that is, I was talking to a dental friend of mine that goes through the same thing. They numb you up, and you might be sitting there for 15 or 20 minutes while it takes effect, and then it takes forever to go away.
Right.
So we often talk about this nowadays. The venous surgery that you do at Vein Clinics of Hawaii is basically you come in, you're an outpatient. You come in by appointment, you the thing set up, you have the procedure done, and an hour later you're out of there.
Yeah. And the primary reason why we've been able to do that, why we've been able to take these procedures out of the operating room and put them in the office, is because of this, newer form of anesthesia that we call tumescent anesthesia. It's really revolutionized not only vein care but a whole lot of other things, and made it much all these procedures much safer for the patient.
It would seem to me also, gang, and this. Some of you are probably thinking of this question because I know I am. It would mean that maybe the service is a little bit more portable. That when needed, somebody could even be treated if they were too infirm to travel. that they could be treated sufficiently and well with the modern equipment you have in their own home, for instance.
That's an interesting concept.
Yeah. Not that you want a house call Dr. Vein guy, but what I'm saying is that I would imagine that in some cases there's such traumatic injury that a lot of things get hurt. Mm-hmm. And if somebody has to stay right there, the professionals by category can come in and come out and do their thing. And and
theoretically you could. There would be some difficulty for that, but actually way back, back in the early 1900s when surgery was first starting to be developed, surgeons routinely went to the patient's house, especially if they were wealthier, and had their appendix out or whatever.
Well, there's another thing now, and we haven't broached this yet. And before we move on to our final, chapter in this particular show, I think that maybe the recovery is the thing that everybody's excited about. But I'm still thinking that it is pretty. You have to pick and choose. You have to know what to look for, and you have to know what to expect. So that must mean there's a great amount of communication between you and a patient.
Oh yeah, we try to describe the whole process to everybody to the greatest amount of understanding that we can, because the expectation of the patient is a huge part of the ultimate outcome.
Sure.
And they, the patient needs to know what's going to happen to them. Sure.
Well, that I was saying about that is because at the end of the day, you have to file in for me a request to my insurance carrier to make sure this is all done. And I'm guessing that almost all of these things that we've been talking about outside of the spider veins, yes, they are insured and they are covered by insurance.
Yes. Yeah. Basically, everything we do with respect to vein care, except spider veins, as you say, is covered by Medicare and insurance carriers.
What about some of the things that follow you home? I mean, I saw in this last question that this woman says, my mother gets woken up constantly by muscle cramps, Charlie horses, or pain in the legs. Is this to do with the veins, or could it be something else, or all of the above?
Yeah. Well, all of the above. Mm-hmm. But this is a good question because it sort of reflects the fact that most people don't know that there is a connection between muscle cramping of the legs and venous insufficiency. So, we, and especially in the older age group, patients that we see, muscle cramping can be a tremendous component of the overall picture with respect to their veins. And muscle cramping, although, you don't think of it, if you're not bothered tremendously by it, you don't think of it all that much. But in these older folks, it's interrupting their sleep. They have to get up in the middle of the night 2 or 3 times, walk around and try to get rid of that cramp before they can go back to sleep. And it's tremendously disruptive.
Yeah, I was going to say, I've heard some people that get woken up by a horrific cramp in their leg, and they really can't do anything. Usually you're told, point your toes in the opposite direction. What if you can't?
Yeah.
What if you can't reach your toe to pull it or push it or do whatever you want to do? From what I understand, this can be very scary to some people because they just don't know when it's going to stop or if it's going to stop.
Yeah, if it's going to stop. And at the very least, they're, losing sleep. And, when that happens night after night, it can be problematic with respect to your quality of life. But venous insufficiency is just one of the reasons why people might have muscle cramping.
Sure.
A couple of other ones are muscle overuse. If you're
the day after the marathon, you've used your muscles a lot.
Exactly. Dehydration. Dehydration is a big one. Because a lot of people aren't drinking enough water throughout the day, and so usually if somebody comes in with muscle cramping, the first thing we tell them is, hey, to start drinking plenty of water.
Sure. You got to remember one thing. I love this. Every time the doctor's going to say, I'm going to jump over that. You can't gain weight drinking water. Unless I take that back. If you overhydrate, I guess you can. But the bottom line is your body says no. That's enough water for this sip.
Yeah.
But you need to have that. You need to have that satiated feeling, right?
Sure.
Otherwise, you're going to get muscle cramps or whatever else happens to you when you sleep.
Yeah. You it's hard to drink too much water. Now, You can. There is a way that you can drink too much water.
Yeah, I've heard about that.
That's actually going to deplete to impact your kidney function. But you have to drink a lot of water to make that happen. And it just in general, most people don't drink enough. So we always encourage people to make sure that they're well hydrated. And
I remember seeing some things that there was a hike in the jungles in wartime, and there's no water. So when you finally find some water, you drink as much as you can.
Yeah.
And when you drink as much as you can, that's not good.
It
might be a bit too much.
Yeah. So, and then mineral depletion. If people don't have enough magnesium, potassium, calcium, those kind of things in their diet, then that can also be a cause for muscle cramping. Usually, again, when people come in and they're talking about muscle cramping, primarily the first thing I tell them is, maintain good hydration and probably go and get, if they're not, get a magnesium and calcium supplement.
Sure.
Just from Walmart or wherever.
I
start taking that.
I did notice one thing, Doctor, I've got to ask you, and that is, every now and again, when there's nothing wrong with you, wouldn't it be good to know how your blood work is, how you are, and then it's a matter, I guess, of you want to do an annual checkup or a semi-annual checkup or whatever, is ask for maybe a fasting blood test. Where am I? And are you taking supplements or should you be taking some? When you read those things, can't you tell right away what a patient needs or has too much of?
Sure.
Yeah. Pretty amazing.
And I think, getting a routine sort of profile of, blood chemistries and your blood count and all those sort of things, blood sugar, as you said, especially after the age of, 35, 40, every year, every couple of years, you can't go wrong.
And the good news is about that, or the bad news is, and we talk about this often, I've asked Dr. Juleff on many occasions, can nutrition or your diet be contributory, or can it help? And I remember it was kind of sketchy that there was no really good line to it, but we often hear about how older people tend to eat, they get habitually where they eat a peanut butter and toast in the morning, tuna at lunch, piece of chicken at night. That's it.
Yeah.
Maybe there is not enough of some of the things you need in those foods that you're eating.
There may not be. Yeah.
So isn't that going to be told? It may not be that you need to take a whole bunch of supplements. It may mean that you just have to vary your menu a little bit.
Well, yeah, just good nutritional eating in general, I think, is very, very important. Yeah. And I think as the years go by, we're understanding that more and more. The younger generation today, I was talking about this with somebody else here recently, they really have gotten very nutritionally conscious.
I've seen that. People read the labels and go about getting books to match things up.
I know my kids, they're very much into very healthy, organic, and healthy eating, and making sure that what they're taking in is good, nutritionally balanced, types of foods. And we never really thought about that when I was young. We didn't.
Well, I
think
think
about those
basically, things. We weren't hunter gatherers, especially in the cities. But mostly back in my day, it was working moms were kind of rare. So moms had a lot of time to nutritionally plan out meals and do all the cooking, and that's what they became so excellent at. And thank goodness for them, because they probably kept a lot of us out of the hospital.
Right.
Okay, so and that was the end. So we end up talking about mom a little bit here. Getting up constantly with muscle cramping.
Yeah.
Let's leave that at a place where it can be. Are there what are the risks attached to that? Muscle cramping and all of that. How can it really hurt you?
Well, I think muscle cramping isn't going to permanently injure you in any way, but it's basically it's a sign of something that may not be right. So we have to decide, what are the potential causes, and does it warrant evaluation? And in general, if people have tried, some of the immediate remedies like hydration and mineral supplements and all that sort of thing, then at that point it's time to evaluate their venous system, because venous insufficiency is definitely a cause. And when we fix it, people do tremendously. As a matter of fact, I think some of our happiest patients are patients who have come in with their primary complaint being muscle cramping.
Yeah, that's wonderful.
And they have that relieved, and it changes their whole outlook on life.
Okay, and that being said, that's a good way to put the program at a junction. We hope that you've enjoyed and you've learned something today. If you want to know a little something, go to VeinClinicsOfHawaii.com online. That's VeinClinicsOfHawaii.com. Or you can drop me a line, the Mike Buck Show at gmail.com, if you want to hear something on the show with Dr. Juleff and I. We'll see you next week. In the meantime, have a good, healthy week, and make sure you do the right things at the right time, and you'll be walking pretty well.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, VeinClinicsOfHawaii.com. That's VeinClinicsOfHawaii.com.